Welcome back to Ask the Expert, where we break down the science behind bleeding disorders and the treatments changing lives. My name is Amy Board. I am your host, and today we are continuing to dive into something that's rewriting the playbook on hemophilia care: rebalancing agents. We're taking a closer look today at inhibitors and how these new therapies might open doors not just for those with hemophilia A or B, but also for individuals with rare and ultra-rare bleeding disorders who have long been left behind. And as always, we'll break down the science in simple terms. Today, we're joined by 4 of our experts. Dr. Ben Samuelson-Jones will be back with us. Dr. Tammy Singleton, Dr. Patrick Ellsworth, and Dr. Mark Redding will all be here. And we're sticking with an analogy we've used before, just because it's perfect for this. So we're back on the playground at the seesaw. You know, when it comes to clotting and bleeding, it's all about balance. We'll continue to play after this message.
Health equity starts with understanding. Meet Shelley, a woman whose hemophilia diagnosis challenged stereotypes and inspired her to drive change. After years of unanswered questions, Shelley's story highlights the power of health literacy to close care gaps and uplift underserved communities. Scan the QR code or click the link in the show notes to watch her inspiring journey and learn how health literacy transforms lives.
A big thank you to our presenting sponsor, Sanofi. We could not do this podcast without them, and we're grateful for their continued commitment to educating our community. So let's take a closer look at inhibitors. If your clotting system is a seesaw, with one side for clotting, your procoagulants, and the other for preventing clots, your natural anticoagulants, then inhibitors are like someone throwing a wrench into that entire thing. Even when you try to add what's missing, your body pushes back, just keeping things off balance. Let's hear from Dr. Ben.
So an inhibitor is an antibody that recognizes factor IX and develops. There's been some debate about how frequently people with hemophilia B develop inhibitors. Historically, it said less than 5%, but I think the most recent data from Europe is up to 10%. And it's clinically significant because if you have an antibody against the factor IX, you can't give factor IX treatment to prevent bleeding or to treat bleeding. And therefore, you need bypassing agents like 5A or 7A. And one of the great potentials of non-factor therapies are they'll work regardless of the presence of inhibitors. And that's true. And the very mechanism of action will make them work for inhibitors in hemophilia B, in hemophilia A, and then any other rare inhibitor you might have against factor 7 or factor 10 or factor 5.
So if treatment with replacement factor is like trying to tip the seesaw back into balance, an inhibitor blocks your ability to do just that. This challenge isn't true for hemophilia. Many rare bleeding disorders face similar barriers, especially when there isn't even a replacement product available. Dr. Patrick Ellsworth confirms.
I think the biggest winners initially are the hemophilia B patients because they just haven't had the equivalent yet. You know, they haven't had their Hemlibra, their emicizumab. But with inhibitors, they just, it's been really miserable for them.
When inhibitors develop, it's not enough to just push harder on one side of the seesaw. You have to find a completely new approach. And that's where rebalancing therapies can come in. Dr. Redding explains.
If I think about what are currently the biggest unmet needs in hemophilia, I mean, we've got a lot of really good treatments for hemophilia, like you said, but there still are some big unmet needs. The first one that comes to mind is folks that have hemophilia B and a factor IX inhibitor. So that's not a lot of people. So hemophilia B is less common than hemophilia A, and not that many people with hemophilia B make inhibitors. But for those people who do, we do not really have a good treatment for them still.
And for those living with rare factor deficiencies, like factor 5 or 7 or factor 11, the problem can be even bigger. Some don't have a therapy to begin with, which means their seesaw has been off kilter for a long time with no real tools to fix it.
If you're missing any portion of the coagulation cascade, you can have a bleeding disorder. And many of those disorders don't have factor replacement because it's too rare and no one has commercialized it. And so, for example, factor 5 deficiency, the only way to replace the factor 5 is with frozen plasma, which is how we treat hemophilia 70 years ago.
So here's the exciting part. These new therapies don't rely on replacing what's missing. Instead, they shift the other side of the seesaw, easing off the forces that prevent clotting to bring things back into balance. Dr. Redding has more.
We don't have a medicine right now that provides prophylaxis like we have for all of our other types of hemophilia individuals. We don't have a good prophylaxis treatment for hemophilia B inhibitor patients. And so these new drugs definitely will address that unmet need, which is huge. It's a small number of people, but it's a huge unmet need.
These rare disorders haven't had the same spotlight or innovation, partly because they're rare. But what if we had a way to help them all without needing a different treatment for each one? Let's get Dr. Tammy Singleton's thoughts, because she always has great ones.
Where is an observational study that you can participate in? And the power is in numbers, right? So if it's a group of you guys and you're living with ultra rare bleeding disorders, you know what? Let's get together and have a potluck and, everybody turn on some music and let's put up a vision board and let's say, hey, where are the observational studies, around here that we can stand up and be counted? And then, hold people accountable. When you participate, go, excuse me, where are the results of that? Where is this published? Follow it. Hold people accountable.
Absolutely. Stand up, be counted, and follow the story. That's not advice just for research. It's advocacy. Because when the rare disease community speaks up, real change can follow. So let's switch gears. But wait a minute, let's stay at the playground. Imagine your clotting system as a tug of war. On one side, clotting factors are pulling hard. On the other, anticoagulants. If the anticoagulants are too strong, we shift that balance, not by adding muscle, but by easing the pull on the other side. Dr. Patrick shares a story from one of his mentors who got him interested in hematology.
Peter Quides is a guy who taught me a lot in residency, got me interested in hemostasis. And he did that too. He would just draw out like a little seesaw with patients and would say, okay, look, on one side, you've got your body wants to clot. And that's like your factor 8, your 9, your 10, your thrombin, prothrombin. And on the other side, you've got your protein CNS, your antithrombin, your tissue factor pathway inhibitor. And those things keep it from getting out of control. And we want to be in balance, like everything in the body, like the word homeostasis says, we want to be in some sort of stasis or balance. And in bleeding disorders, that balance is obviously out of whack and you bleed. And there's people who have inherited protein S deficiency, protein C deficiency, antithrombin deficiency, which is a particularly severe one, factor 5 Leiden, which keeps the factor 5 protein from being able to be broken down by protein C. That's a separate clotting disorder. And so there are these ways that nature kind of goes haywire and then, that this balance isn't struck. And so it's been an interest for a while since, the genome was sequenced that, like, hey, can we leverage these proteins that we know are there and the way they act to treat bleeding disorders, which, spoiler alert, you can.
Instead of adding more players to one side of the rope, rebalancing therapies change the game by loosening the pull from the other side. And that's especially helpful for people with inhibitors, because when your body blocks what you're trying to add, tugging harder doesn't help. But if you ease the tension from the opposing side, you can still bring things back into balance without a fight.
We are not replacing what's missing. We are going to the entire system globally, and we are putting things that were out of balance back into balance by adjusting not the procoagulants over here that we don't have, but the anticoagulants over on this side. So if you are living with hemophilia without inhibitors, and I could potentially treat you by just replacing what's missing, you're still going to respond to a rebalancing agent because you are missing the procoagulants, right? And the anticoagulant system is now dominating. And so I'm going to take off some of these anticoagulants and I'm going to put you back into balance and have thrombin generation. So that if you're a patient and or someone living with hemophilia with inhibitors, okay,
So if tug of war isn't your thing, think of it like adjusting the thermostat in a house instead of heating just one room. Rebalancing therapies take that whole system approach, and that's why they could help people with rare deficiencies too, not just those with inhibitors, as Dr. Singleton will explain.
So now I can't replace what's missing because your antibodies, those inhibitors, will just pick it right off out of circulation. And the only way I could otherwise treat you if you're going to pick off out of circulation when I put it back in terms of those coagulants, is to use a bypassing agent. So I'm bypassing the need for factor 8 or factor 9. I'm skipping over that step and I'm force activating factor 10. The end game is still thrombin formation, right? Thrombin formation and having that clot. So instead of using a rebalancing agent to have thrombin formation, if a person is living with inhibitors, I'm going back to this rebalancing agent, and I am going to prevent bleeding now by, remember, we still have this imbalance, right, with the procoagulants here, because now I have inhibitors on board. I can't treat it with factor 8 or factor 9, can't replace what's missing. And I want to have an alternative to using a bypassing agent, right, in terms of that end game, thrombin formation. So same thing. I'm now going to take off an anticoagulant on this side. I'm going to put things back into balance, and I'm going to have thrombin formation, even for a patient who's living with an inhibitor.
So who's most likely to benefit? Right now, people with hemophilia B and inhibitors are seeing the biggest shift. Right, Dr. Ellsworth?
At least initially, I think that's going to be the biggest need that's going to be filled is the hemophilia B folks, especially hemophilia B with inhibitors. They've just had nothing because factor 8 deficient folks have kind of looked at them with envy at the half-life of their missing factor and said, like, man, you get to infuse once a week or every 2 weeks. That's unfair. So there may be even more coming that will surprise us even more.
As we mentioned, repurposing these therapies for rare conditions could be a game changer if the community and the pharmaceutical manufacturers come together. Dr. Ellsworth has a thought on this.
I think another question of where these are going to fit in is as we get more data with really active people, especially like competitive athletes. Because I think things like fitusiran, so you bring an antithrombin down, and even like a protein S antibody, those could potentially have a role for very active people where you've gotten hemostasis essentially close enough to normal where emicizumab doesn't quite do the trick. That could be a role.
And what about the rare bleeding disorders? The same science could be repurposed for them if we can get research support behind it. It's a big if, but the potential is huge. Here's Dr. Ben with more.
You would rationally think that the mechanism of action, if you decrease factor 5, decrease in any of the other anticoagulant factors that we talked about, is most likely to be similar as in patients with hemophilia A. There needs to be buy-in from the community and the pharmaceutical company to say that this is an indication that may not be a moneymaker, but could have profound effects on the lives of these people.
Instead of building entirely new treatments for each rare deficiency, we could use this rebalancing strategy across conditions. That could be a win for the industry and, more importantly, for patients.
I think for like the people with severe factor 7 deficiency who have severe bleeding from that, or the 11s, which in parts of the country, especially, Northeast and New York and that have a lot of patients with it, they would stand to benefit. And, we may not ever even get trials for some of that, because it's just, it's going to be rare and, the incentive for a company to develop it specifically for that isn't going to be there. But I think those are things that I'm interested in too. And even looking at things like emicizumab and MIM8 for those rare deficiencies, even sort of repurposing them, so to speak, is something that I'm interested in looking at and hopefully can get there because, again, I don't think, industry does an opinion time here. Everyone's got opinions about kind of industry and academia and how they interact. But I do think industry have done a lot of good things for patients in the hemophilia space, right? And they've made factor and medications available for people all over the place. But because that incentive isn't necessarily going to be there to develop a whole new drug for a very rare, specific factor deficiency, I think that's where repurposing these sort of more universal type agents like the protein S antibody could be a big win for industry and for providers and patients, that we'd have kind of something that's there for everyone.
But before we wrap up, one quick but important note. Rebalancing therapies are designed to prevent bleeds, not to treat active bleeding. Here's Dr. Singleton.
Remember, these rebalancing agents prevent bleeding. We're not treating an active bleeding episode if something were to occur. So you would still use a bypassing agent to treat an active bleeding episode, right, in an inhibitor patient, for example. If you're someone living without an inhibitor, you would still use a factor concentrate replacing what's missing in a patient living without inhibitors if a severe bleeding episode were to occur or if a surgery, right, was needed.
You would still use a bypassing agent to treat an active bleeding episode or factor concentrate if you're not living with an inhibitor. We're at a turning point, moving from patching problems to reworking the entire system. Rebalancing therapies shift our focus from what's missing to how we restore balance.
Back when it was first described, if females did have bleeding that was abnormal, they were deemed to be hysterical. It was a medical fact that women could not have hemophilia. And of course, now we know that that is absolutely not true. That has been a huge barrier for women and girls to this day of getting accurate diagnosis and access to care and treatment. Women and girls are not included in clinical trials. And the issue is that if women are not included in the data, that door is never open for them and they don't get access.
I've talked to many women that even can't get doctors, can't even get diagnosed. I want the future generation, especially for women with hemophilia, to be treated the exact same.
We've never done this before. We've never collectively come together to talk about what it is like to be dismissed.
Thanks for listening to Ask the Expert. Want to dig deeper? Head to the show notes. And if you're a visual learner, grab a pen and draw a seesaw. It really does help, trust me. Until next time, stay curious, stay balanced, and we'll see you back here soon. Did you know bloodstreammedia.com is your one-stop shop for all podcasts for the bleeding disorders and rare disease community? There, you can find links to the Global Hemophilia Report and our flagship podcast, Bloodstream, with your hosts, me, and Patrick James Lynch. Also check out Flow, which is straight talk about extreme periods, and The Pain Pod, which is an in-depth storytelling odyssey of chronic pain. All this and more on bloodstreammedia.com, the #1 podcast network for rare disease. Have an idea for a future episode of Ask the Expert? Or have a question that you would like to hear one of our experts answer? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on Facebook and on Twitter and on Instagram and all those social media channels. I am your host, Amy Board, and until next time, stay curious, my friends.